Hi, my name is Jeremy Murray, and this is my health policy proposal for MBA 721. In 2000, Congress passed the Benefit Improvement and Protection Act, which included provisions to decrease fraud, waste, and abuse pertaining to the provision of orthotics and prosthetic devices. Section 427 of BIPA was designed to ensure that reimbursement for all prosthetic and custom fabricated orthotics by CMS would only occur when the devices were furnished by qualified practitioners and qualified suppliers. In response to this provision, the orthotic and prosthetics industry enacted licensure requirements in 14 of the 50 states. In 2005, CMS issued Transmittal 656, which specified that Medicare payment contractors must have claims processing requirements in place to ensure that, in states requiring licensure, payment for O&P services were only being made to those individuals and entities that met the relevant licensure specifications. Both of these provisions, designed to improve accuracy in payment and the quality of care, have not been enforced in any extent by CMS. What they have done instead is ramp up RAC audits, which are audits directed towards legitimate providers to ensure that all the paperwork I's are dotted and T's are crossed. In the O&P world, providers have to pay for all the materials and componentry up front, then chase down reimbursement. Particularly in prosthetics, the componentry can run tens of thousands of dollars per prosthesis, which can really decrease available cash flow and hamstring a company, especially if it is a small business. The first part of proposed legislation would require improvement to the Healthcare Common Procedure Coding System, or HCPCS system, which is how O&P services are billed. Using this system, providers use a series of L codes to indicate the devices issued to the patient. It classifies each device as an OTS, or an off-the-shelf device, custom fit, or custom fabricated. OTS devices require minimal self-adjustment for appropriate use and do not require an expert to properly fit the device to the individual. Custom fit items are those that are pre-made but require significant modification, skills, and expertise to fit to a specific patient. In concept, these devices would not be useful to another patient once the custom fitting by a qualified practitioner had occurred. Custom devices are fabricated from raw materials, are patient-specific, and are indicated when an OTS or custom-fit device could not be utilized based on the patient's anthropomorphic measurements, body habitus, or physical condition. To improve this system, two things need to be done. First, OTS devices should be eliminated for reimbursement, as they do not require the skills of an expert to fit. This would immediately decrease Medicare costs by shifting the cost of the device as well as the decision to utilize the device from CMS onto the patient. Far too many devices have been discarded while being essentially unused. The second part of this is expansion of the existing HCPCS code set to include additional designs and material. Other professions, such as occupational therapists, use direct molded materials for short-term pathologies, such as tendon lacerations or fracture bracing. These services are appropriate, but are created using an entirely different process and cheaper materials, which are not accounted for currently. The second part of the proposed legislation would require licensure in all 50 states. By mandating licensure, CMS would be assured that payments were being made only to qualified individuals and suppliers, which is identified previously in their legislation as efforts. Currently, there are 14 states that require O&P practitioners to meet licensure requirements. According to the American Orthotics and Prosthetics Association, licensing requirements in most states track very closely with the typical certification requirements of training and education, so that an individual who is not certified will never be able to meet eligibility for licensures. In other words, it is possible to be certified and not licensed, but it is virtually impossible to be licensed and not certified. The third part of the proposed legislation would eliminate profession-wide exemptions to the licensure requirements. Currently, there are several medical professions that are exempt, which creates a loophole for unqualified individuals to provide O&P care. BIPA granted exceptions to healthcare professionals such as physicians, physical therapists, and occupational therapists. This allows them to submit claims to CMS for O&P services regardless of their actual qualifications to provide the service. Without going too far into it, physicians, OTs, and PTs only receive a few days of training in O&P care. Orthotists and prosthetists, by contrast, receive 2 years of master's level education, followed by a 1-year residency, and then are required to pass 3 national board exams. To put it simply, orthotists and prosthetists are the only truly qualified professionals when it comes to the provision of custom fit and custom fabricated orthotic and prosthetic devices. The last part of the proposed legislation is to create safe harbors for certain professional arrangements, which should be extended to include O&P services, particularly when the practitioner is employed by the referral source or sources. Large physician practices or hospital systems may want to employ an O&P practitioner, which would provide services exclusively for the group as needed. With an established safe harbor, the physician group could facilitate a professional relationship with a single identified practitioner or business, which would likely lead to accuracy in patient care and create savings for CMS. These requirements are not intended to limit the ability of healthcare workers to provide usual and customary patient services within a professional scope of practice. They are, however, intended to delineate which items may be furnished without additional certification. In terms of orthoses, there has been and should continue to be some limited ability of other health sciences to provide these services. High-level devices, such as those that are intended for long-term usage for weight-bearing pathologies or intended to produce significant biomechanical correction, should only be provided by qualified individuals. Prosthetic services should be a statutorily excluded service to all professions, except for when provided by a certified prosthetist. According to the research conducted by Dobson and Davanzo, of the $3.62 billion paid by CMS from 2007 to 2011 for O&P care, nearly one-third went to unlicensed providers or those who failed to meet the accreditation requirements. By simply requiring licensure and limiting reimbursement to those individuals and facilities that are licensed, CMS can eliminate over $1.2 billion in improperly paid claims. For example, in 2005, the issue of payments to unlicensed O&P facilities in Florida gained national attention when 48 unlicensed medical facilities billed CMS for approximately 21,000 artificial limbs that were not medically necessary or provided to patients. This massive incident of fraud directly cost CMS approximately $122 million. None of these facilities, however, were members of any of the groups shown here, which are the major entities responsible for monitoring individual and facility O&P qualifications. In fact, none of the facilities charged with fraud even had so much as a licensed prosthetist on staff, yet received payment for prosthetic services by CMS. With the enactment of the proposed legislation, though, the situation would have never been able to occur in the first place. Another thing to be considered is that prior to 2014, approximately 28,000 potential Medicare suppliers have indicated their intention to submit claims for orthotic and prosthetic care on their CMS 855S enrollment form. At this time, however, there are only about 1,300 accredited facilities in O&P. This discrepancy reflects the fact that a large number of suppliers are routinely billing or intending to bill Medicare for O&P services without certification, accreditation, or licensure. This legislation would change the way in which orthotic and prosthetic care could be provided, which would have a significant impact on public health. The legislation would not change the referral process, but it would make it necessary for the physician to establish professional relationships with area O&P providers and make referrals to those facilities as patient care dictates. Much like physicians make referrals to PTs or OTs for specialized services, this legislation would ensure that patients in need would be cared for by professionals specializing in the evaluation, construction, and delivery and upkeep of the O&P devices. The most significant piece of the proposed legislation are in terms of future cost savings to the Medicare program by eliminated payments to unlicensed providers. It would also ensure significant cost savings for both CMS and the patient through modification of the HCPCS system. For CMS, non-coverage of OTS items would create a significant savings. For the patient, OTS devices would no longer be priced according to a fee schedule, which would allow them to be sold as costs dictate by the quality of the item, the business costs to obtain the item, and patient preference. Finally, payments for unused, poorly fit, or unnecessary items would be reduced by ensuring that patients who require the skills of an orthotic or prosthetic specialist are only able to be treated by those who specialize in the necessary devices. In conclusion, this piece of legislation would go a long way to reduce fraud, waste, and abuse in the Medicare system. By using a preventative approach, it will eliminate unnecessary payments to unqualified providers, increase overall quality of care, and ensure that these patients are receiving care from licensed providers. The key to it is the enforcement of these parameters by CMS, which has so far been reluctant to follow their own guidelines. Thank you.